If you are looking for the absolute fastest way to understand acyanotic congenital heart disease, well, this is your deep dive. We're not just, listing defects today. We're really aiming to give you the anatomical, the embryological, and the genetic shortcut.
Yeah.
To understanding why these major structural problems actually happen.
That's exactly right. We're drilling down into basically the 4 main acyanotic defects. You've got VSD, ASD, PDA, and coarctation of the aorta.
The big ones.
The big ones, yeah. And linking them straight back to that really critical and surprisingly short construction window.
Right. Weeks 3 through 8 of gestation. It's amazing how much happens then.
It's incredibly compressed, and that's where things can go wrong structurally.
So our mission today is essentially to connect these big clinical syndromes you see, like Down syndrome or, say, fetal alcohol syndrome.
Yeah, the ones you encounter.
Directly to the specific cellular failure they cause in the tiny embryonic heart. It's a really cool mechanism-first approach.
It is, and we think it helps transform some pretty dense source material into, high-yield, memorable knowledge for you.
Hopefully much more memorable this way.
Ultimately, these defects really just represent a permanent failure, a failure of cells migrating, aligning, fusing.
All that complex choreography.
Exactly. And if a genetic hit or some maternal insult affects the fetus outside that week 3 to 8 window, well, you might get functional issues later, maybe.
But not these fundamental building problems.
Right. You won't see the actual architecture collapsing like we see here. The timing, it really dictates the specific pathology.
Okay, that's a great framework.
Right, good.
So let's unpack this by meeting the 3 main construction crews, or builders, as you call them.
Yeah, the builders. They have to work perfectly together during that critical window.
So who's builder number 1?
Builder number 1.
Yeah.
The endocardial cushions. You can kind of think of them as the septal architects.
Okay.
They start as these mesenchymal cells, and they migrate into this stuff called the cardiac jelly.
Cushions.
Yeah.
Sounds soft, maybe like padding.
Yeah.
But you're saying they have a huge structural job.
Oh, absolutely massive. They're not just padding. Their main job is bearding the atrioventricular valves, so the mitral and tricuspid valves.
Okay, the doors between the chambers.
Right. And also the central part of the septa, the walls, specifically the atrial septum primum and that really critical membranous part of the ventricular septum.
So what happens if they don't meet up right, if they fail to fuse?
Well, if the superior and inferior cushions fail to fuse properly in the midline, that's when you get endocardial cushion defects, or ECD.
What's ECDs? No.
Sometimes also called AV canal defects. Same thing.
And linking that back to genetics, this is the Down syndrome connection, right?
That's the one. Failure of these endocardial cushions, the ECD, is really the absolute classic cardiac lesion we associate with trisomy 21 Down syndrome.
Wow. So the location of the hole literally tells you which builder had the underlying genetic issue.
That's the core insight. Yeah, it maps directly. Okay, moving on. Builder number 2 is the neural crest cells. Think of them as the outflow engineer.
Neural crest. So these come from the nervous system.
That's right. They migrate from the developing neural tube right into the heart. Their big job is forming the conotruncal ridges.
And this is the crew responsible for that spiraling division, the part that splits the single outflow tube into the aorta and the pulmonary artery?
Exactly, making sure the great vessels are hooked up correctly, proper alignment of the plumbing.
Crucial.
Very. And they also contribute a significant piece to that final bit of the membranous septum we mentioned.
Okay, so they're involved in the septum too.
They are. Now, this crew is, well, notoriously sensitive. The sources show they're highly vulnerable to teratogens like alcohol. So if these neural crest cells get disrupted, you get misaligned plumbing, outflow tract problems.
Okay, that makes sense. And it suggests that maybe defects linked to these cells might be more variable.
That's a fantastic point.
Compared to the cushion defects you see pretty consistently in Down syndrome.
Absolutely, because it often depends on the dose and the exact timing of the environmental hit, right? So the outcomes can be, highly variable.
Interesting. Okay, builder number 3.
Builder number 3 is the primitive myocardium. This is basically the foundation wall.
Okay.
It's simply the robust heart muscle tissue that forms the main bulk of the ventricle walls early on.
This sounds like the reliable crew member laying the groundwork.
Pretty much. They are the foundation. They form the muscular wall, especially the muscular septum between the ventricles. They start building around week 4.
But they don't finish the wall completely.
No, and this is key. The muscular septum intentionally leaves a gap. It's called the interventricular foramen.
Okay.
And that gap must be filled in later by the membranous septum. And that membranous septum is like the final cement poured by the other two builders.
The cushions and the neural crest cells.
Exactly. They all have to meet perfectly there.
That three-part fusion. Okay, that really explains why we see such variability when we look at holes in the wall, like VSDs versus ASDs.
Precisely.
So let's start with the ventricular septal defect, the VSD, which, maybe not surprisingly, given that complexity, is the most common congenital heart defect overall.
It is the most common, yeah. A VSD is just a defect, a hole in that shared wall, the interventricular septum.
Right.
And it causes oxygenated blood to shunt from the high-pressure left ventricle over to the right ventricle. That's your classic left-to-right shunt.
So thinking about our builders, the most common type, the membranous VSD, what, about 80% of them?
Around that, yeah.
That must be a failure of that complex fusion point.
It's the ultimate alignment failure. It requires the perfect meeting and fusion of the endocardial cushion contribution, the neural crest cell contribution, and the tip of the muscular septum.
Wow. So many moving parts.
Yeah, the more moving parts that have to align, the higher the chance something goes slightly wrong. Hence, it's the most common defect.
Okay, so the less common type, the muscular VSD, that's purely an issue with the foundation wall itself, the primitive myocardium.
Correct. Just defects solely within that muscular ridge. Interestingly, sometimes if there are multiple little holes, it's described as a Swiss cheese septum.
Right, I've heard that.
And the key thing clinically about these ones, the muscular VSDs, is that they often close spontaneously.
Oh, really? Why?
Because that robust muscular tissue just keeps growing and remodeling after birth, and it can often fill in those small gaps on its own.
Okay, that's important. Now let's talk about that classic clinical hook, because this confuses a lot of people. Why is the VSD murmur often quiet or even absent right at birth, and then it gets really loud, that classic harsh holosystolic murmur, maybe 2 to 6 weeks later?
Yeah, that timing is crucial. It's all about pressure dynamics, specifically pulmonary vascular resistance, or PVR.
Okay.
At birth, a baby's PVR is naturally high, almost as high as their systemic vascular resistance, the SVR.
Because the lungs haven't been working yet.
Exactly. So since the pressures in the right and left ventricles are pretty similar initially, there's not much force pushing blood across the VSD.
So minimal shunt, quiet murmur.
Minimal shunt, quiet murmur. But then, as the baby starts breathing air effectively over the first 2 weeks, the pulmonary vessels relax and the PVR drops dramatically.
Right.
Now you have a huge pressure difference between the high-pressure left ventricle and the now low-pressure right ventricle.
And that drives the shunt.
That high-velocity jet of blood shooting across the VSD is what causes that loud, harsh, holosystolic murmur you hear best at the lower left sternal border.
That makes perfect sense. Pressure dictates. Flow dictates sound.
Mm-hmm.
Okay, let's move up a level to the atrial septal defects, ASDs.
Okay.
Similar L to R shunting, but these often seem quieter, more subtle in presentation.
They often are, yeah. The most common type here is the secundum ASD, and the mechanism is usually different from VSD. It's typically a true deficiency of septal tissue.
Like a missing brick in the wall.
Exactly like a missing brick. It's either because too much of the first wall, the septum primum, got resorbed during development, or the second wall, the septum secundum, just grew up too short to cover the hole.
Okay, so fundamentally missing tissue.
Right. Whereas the less common type, the primum ASD, takes us back to our familiar builder failure.
The endocardial cushions again, down near the AV valves.
That's precisely a failure of cushion fusion at the lower part of the atrial septum.
And the classic physical exam finding that points you towards an ASD related to that right heart volume overload.
Ah, yes. The fixed, widely split ESSER. Second heart sound.
That's such a high-yield finding for exams and practice. Can you unpack that quickly?
Sure. So the ASD causes continuous left-to-right shunting into the right atrium and then right ventricle. This chronic volume overload makes the RV take longer to eject blood.
Delays the pulmonic valve closing.
Right. So the pulmonic valve closure sound, P, is delayed relative to the aortic closure sound. That makes the split between AROP wider than normal.
And why fixed?
Because normally, when you breathe in, venous return increases, delaying P even more, making the split wider. When you breathe out, it narrows. With an ASD, the RV is always volume overloaded because of the shunt, so that respiratory variation is lost. The split is wide, and it stays wide. Fixed splitting.
Brilliant. Okay, we need to loop back to surgery for the ostium primum ASD. You mentioned it's tricky. Why is repair so hazardous there?
Yeah, it carries a significant risk because that primum defect, being low down near the AV valves, Well, it occurs right next to the tissue that develops into the AV node.
The electrical gateway.
Exactly, the electrical doorman coordinating the beat. So when surgeons are patching that hole, the patch placement is dangerously close to the AV node.
So you risk damaging the node during the repair.
High risk of causing surgical heart block, even complete heart block. It's a known complication specifically for primum ASD repair.
Okay, important distinction. And before we jump into teratogens, let's quickly nail the difference. ASD versus PFO, patent foramen ovale. Clinically, they mean different things.
Hugely different risks, yeah. An ASD, like we said, is missing tissue, a true hole. Creates a continuous L to R shunt, usually.
Okay.
A PFO is different. It's missed fusion. Remember, the foramen ovale is a normal fetal structure allowing R to L shunting in utero. After birth, pressure changes should slam it shut and fuse it.
But sometimes it doesn't seal completely.
Right. The flaps fail to fuse permanently, so you have a potential opening like a trapdoor. It usually only opens transiently and typically with R to L flow.
When would that happen?
Like when you strain, cough, or do a Valsalva maneuver, anything that briefly raises right atrial pressure above left atrial pressure.
And why do we care clinically about that transient R to L shunt?
Because of paradoxical embolus. A blood clot from the veins, say a DVT in the leg, can travel to the right atrium, slip through the open PFO during a moment of increased pressure.
And go straight into the arterial system.
Straight to the brain, causing a stroke. It's a major cause of cryptogenic stroke, especially in younger adults where you don't expect typical stroke risk factors.
Wow. So ASD is about volume overload. PFO is about paradoxical clot risk. Very different.
Very different implications, yeah, based on just how the structure failed.
Okay, fascinating how that works. Let's connect the dots now to the specific root causes those teratogenic time bombs hitting during weeks 3-8.
Right. We already touched on Down syndrome, trisomy 21. The mechanism there is defective signaling involving the endocardial cushions.
During weeks 4-7, mainly.
Yeah, and the classic result is that complete atrioventricular septal defect, or AVSD, which is really a triple threat defect.
This is a primum ASD.
Plus an inlet VSD right below the valves.
And a single common AV valve instead of separate mitral and tricuspid.
Exactly. It's a catastrophic failure of that central cushion fusion.
So clinically, if you see an infant with the typical features of Down syndrome, the hypotonia, the facial features, plus a complex murmur, maybe holosystolic, and a mid-diastolic rumble.
You strongly suspect an AVSD. You know those cushions fail dramatically during that window.
Okay. Moving to environmental hits. Fetal alcohol syndrome, or FAS.
FAS really highlights how vulnerable those neural crest cells are. Ethanol toxicity, the alcohol itself, directly causes neural crest cell death. It can also injure the cushions.
And this can happen throughout that whole critical window, weeks 3-8.
Pretty much the whole window is sensitive.
And the defects are often?
VSD is very common. Also ASD, sometimes PDA. It's often summarized clinically with the mnemonic smooth philtrum plus VSD.
Flat upper lip, yeah.
Or kind of a flat septum. It's a failure of migration, alignment, and fusion caused by that teratogen exposure.
Okay, another common one. Maternal diabetes mellitus. Specifically pregestational diabetes.
Yes, pre-existing diabetes is a key risk factor. Here, the problem is hyperglycemia, high blood sugar during that early weeks 3-8 window.
And how does that mess things up?
High glucose seems to disrupt neural crest migration primarily. So you get structural defects like VSDs or even complex things like transposition of the great arteries, TGA.
TGA is cyanotic, but the mechanism involves those same neural crest cells failing.
Exactly, the mechanism overlaps. So we often say with maternal diabetes, the defects are either built wrong, these early structural issues like TGA, VSD, or later in pregnancy, post-week 20 or so, the baby can develop something different. Transient hypertrophic cardiomyopathy or HCM.
Where the heart muscle gets too thick?
Yeah, but this one is usually reversible. It's caused by the fetus making too much insulin in response to the mother's high sugar. Insulin acts like a growth factor.
Ah, so built wrong early or too big later. Got it.
That's the shorthand. And finally, an infectious cause we need to mention, Tourette infections. Rubella is the classic example here.
German measles.
Right. If mom gets rubella in the first trimester, especially weeks 3-8, it's extremely damaging. The virus seems to damage the endothelium, the lining of blood vessels, and also the endocardial cushions.
And the classic defect associated with congenital rubella.
Patent ductus arteriosus, PDA, is the big one, often along with pulmonary artery stenosis.
Which gives us that textbook triad.
The congenital rubella triad. PDA plus cataracts plus deafness. A devastating combination from that early infection.
Okay, that PDA mention leads us perfectly into the last couple of defects, the outflow tract problems, starting with patent ductus arteriosus.
Right, so the ductus arteriosus is a normal fetal vessel connecting the pulmonary artery to the aorta, bypassing the lungs. It's supposed to close shortly after birth.
But if it stays open, patent.
Then you have a PDA. Postnatally, pressure in the aorta is higher than the pulmonary artery, so you get a continuous L-to-R shunt from the aorta into the pulmonary artery.
Which puts a volume load on
the left side of the heart. The blood recirculates through the lungs, comes back to the left atrium, left ventricle, which have to pump extra volume. LV volume overload.
And the physical exam here is pretty unique, right?
Oh yeah, unforgettable. The continuous roaring machinery-like murmur. It's heard throughout systole and diastole, best up under the left clavicle.
Why continuous?
Because the aortic pressure is always higher than the pulmonary artery pressure after the PVR drops, so blood shunts across the PDA during both systole and diastole.
Makes sense. And you also see other signs.
Yeah, because blood is constantly running off the aorta into the low-pressure pulmonary circuit during diastolic pressure drops. This gives you a wide pulse pressure, the difference between systolic and diastolic, and often bounding pulses.
Okay. Now, we have to talk about the long-term risk. If a large PDA isn't corrected, it can lead to Eisenmenger syndrome.
Right, irreversible pulmonary hypertension.
And shunt reversal. And this causes a very specific finding, differential cyanosis.
Yes, this is a super high-yield concept. Remember where the ductus usually inserts into the aorta?
Just after the arteries to the head and arms branch off. Right. Distal to the left, subclavian artery.
Exactly. So when the shunt reverses in Eisenmenger, R2L, PA to aorta, the deoxygenated blood from the pulmonary artery gets dumped into the aorta after the arm vessels have taken off.
Ah, so the upper body is still getting relatively oxygenated blood from the LV.
Right. So the arms and head look pink. But the deoxygenated blood travels down the descending aorta to the lower body,
making the legs and toes blue and clubbed.
Precisely. Pink upper body, blue lower body. That's differential cyanosis, and it's almost diagnostic of Eisenmenger syndrome caused by a PDA.
Incredible anatomical clue. Okay, last one. Coarctation of the aorta, C-CoA.
CoA. This is simply a narrowing, a constriction of the aortic lumen, usually right around where the ductus inserts, called juxtaductal.
So not a hole, but a blockage. This creates a pressure problem.
Pure pressure problem. Proximal to the narrowing, pressure builds up. Distal to it, pressure and flow are reduced.
Which leads to the classic clinical signs.
Severe hypertension in the upper limbs measured in the arms because they're proximal to the block.
Okay.
And weak or delayed pulses in the lower limbs, femoral pulses, because they're distal. This difference is called radiofemoral delay. Feeling the radial and femoral pulse simultaneously, the femoral one feels weaker and later.
A fundamental physical exam finding. And the amazing imaging clue you can sometimes see on a chest X-ray.
Rib notching. It's quite striking when you see it.
How does that happen?
It's the body trying to get around the blockage. Over time, the intercostal arteries, which run along the underside of the ribs, enlarge dramatically. They act as collateral vessels, carrying blood from arteries branching off before the coarctation to arteries after it, bypassing the narrowing.
Like natural bypass grafts?
Exactly. And the chronic pressure and pulsation of these massively enlarged intercostal arteries literally erodes the inferior surface of the ribs, usually ribs 3 through 8.
Wow. Nature finding a way, but leaving a mark.
Mm-hmm. And we have to mention its associations. CoA is highly linked to Turner syndrome, 45XO.
Right.
And also, because of the chronic upper body hypertension, these individuals are at higher risk for baryaneurysms in the brain's circulation.
Okay, that makes sense. Now, the infantile presentation can be quite dramatic, but delayed.
Yes. Often, a baby with severe coarctation seems fine for the first week or two. Why?
Because the PDA is still open.
Exactly. The patent ductus arteriosus is actually providing blood flow from the pulmonary artery to the lower body, bypassing the coarctation. It's acting as a lifeline.
But then the PDA starts to close.
Usually around 1-2 weeks after birth, as prostaglandin levels naturally fall, the PDA constricts and closes. Suddenly, the lower body loses its blood supply because the severe aortic narrowing is unmasked.
And the baby crashes.
Goes into acute cardiogenic shock, severe heart failure, poor perfusion, it's a medical emergency, requires prostaglandins to reopen the ductus, and then surgical repair.
Wow. What a range of defects from just a few builders getting messed up early on.
It really is striking when you zoom out just how exquisitely precise that development needs to be. We've seen, a single chromosome error leading to a specific cushion failure in Down syndrome.
Right, to alcohol causing neural crest cell death.
To a virus like rubella damaging vessels, all happening, fundamentally, within that same tight 2-month window.
It hammers home that every single acyanotic defect we covered today really boils down to a specific failure, whether it's the neural crest, the endocardial cushion, or the myocardium. Failing at that critical week 3 to 8 stage. And knowing which builder failed is really the key, isn't it? To understanding the defect, the associations, the risks.
That is the core takeaway. If you understand the builder, you understand the lesion.
So this framework should really help you distinguish these defects far beyond just memorizing murmurs.
Absolutely. And maybe this raises an important question for you to consider, sort of connecting the dots. We said VSD is the most common CHD overall because it needs that precise alignment and fusion of 3 different builders.
Right. The cushions, neural crest, and myocardium. High chance of error.
So thinking about that mechanism alignment and fusion failure, particularly involving the neural crest cells, which other major congenital heart defect, maybe a cyanotic one this time, is also fundamentally an alignment and fusion problem linked to those same neural crest cells, leading to really significant long-term issues.
Oh. Yeah, that's a great challenge question. Connecting today's mechanisms to the broader universe of CHD, something for you to definitely mull over as you integrate this deep dive.
Yeah, think about which major cyanotic defect involves malalignment driven by neural crest issues.
Excellent food for thought. Thank you so much for joining us on this deep dive.
Yeah.